So good afternoon, everyone. I know you're headed for the next break, so I'll get you through this as briefly and as interestingly as possible. Before I begin, I'd like to thank Dr. Sharma and Dr. Kinney for their relentless support of this Nurse Tech Symposium over the years. I've been here since the first one. Nobody knows my age. And I'd like to thank Beth and Antoinette for organizing this incredible learning experience and for inviting me to speak. I have no disclosures. Okay. Diabetes is closely related with cardiovascular disease. In fact, one could say that diabetes is a cardiovascular disease. Therefore, it is closely related with an increased risk of heart attack, stroke, and amputation. With the rising tide of diabetes around the globe, the double jeopardy of cardiovascular disease and diabetes is said to result in an explosion of maximum proportions. 29 million people have diabetes. That's 1 out of every 11 people. 1 out of every 4 do not know they have diabetes. 86 million people have pre-diabetes. That's about 1 out of every 3. 9 out of 10 people do not know they have pre-diabetes. 1.4 million Americans are diagnosed with diabetes every year, equating to a $245 billion industry in medical costs alone in the United States in 2012. Diabetes is the number 7 cause of death. Cardiovascular disease is still number 1. 1 in 3 will have diabetes by the year 2050 if current trends persist. So this slide that I found on Trump.org shows that diabetes does not build walls around race. As shown here, at the top of the leaderboard are the American Indians, you see the non-Hispanic blacks, and the Hispanics. Interestingly, Filipinos are at 11.3%. While my people didn't make it to the top 3, they certainly have managed to gain momentum. Diabetes is a group of diseases marked by high levels of blood glucose, resulting from problems in how insulin is produced, such as in type 1, how insulin works, such as in type 2, or both. I will focus on type 2. So as we all know, the risk factors for type 2 diabetes are history of hyperglycemia, prediabetes, gestational diabetes, being obese, having a sedentary lifestyle, genetics, family history, race and ethnicity, advanced age, high blood pressure, and dyslipidemia. So the ABCs of diabetes are an A1C, which is the average blood glucose over a 2 to 3 month period. It's the blood check with a memory. The current ADA A1C guidelines are recommended at below 6.5%, provided that it can be achieved safely and without excess hypoglycemia. So just for a reference, so you know where your patients live when you see them, when you see one number or the other, a 6% A1C is about 126 plasma glucose. 8% is 183 plasma glucose, and 10% is 240. And we also look at the blood pressure and the cholesterol levels, particularly LDL levels. Prediabetes is a condition in which individuals have high blood glucose or A1C levels, but not high enough to be classified as diabetes. The precursor stage is often referred to as that gray area. It is the simultaneous presence of insulin resistance and beta cell dysfunction. Those with prediabetes have an increased risk of developing type 2, heart disease, and stroke, but not everyone with prediabetes will progress to type 2. The Diabetes Prevention Program was a large prevention study of people at high risk for diabetes, showed that lifestyle intervention that resulted in weight loss and increased physical activity in this population can prevent or delay type 2 diabetes and in some cases, return blood glucose levels to within normal range. So when did the term prediabetes become the fashion bling word in the world of diabetes? And why should we care? Well, it gained some notoriety at a press conference in 2002, but it was first coined in the American Journal of Obstetrics and Gynecology in 1964. Prediabetes and type 2 diabetes often co-segregate with hypertension and dyslipidemia. and present as manifestations of the metabolic syndrome, which affects 47 million people in the United States. Therefore, nearly 15 million little Americans have prediabetes, running around whose prediabetes will pretend to type 2 diabetes within 10 years. So this is why we should care. These numbers should bother everyone in this room. Moreover, on a given day in our very busy cath lab, we see a daily average of anywhere from 30 to 50 patients. Half of those patients being pre-diabetic, and they don't even know it. So what are the risks of cardiovascular disease? Epidemiological studies have shown that prediabetes confers an increased risk of cardiovascular disease, right? We know that. The close association of type 2 diabetes with cardiovascular disease has led to the hypothesis that they both share this common antecedent, that being of the metabolic syndrome. The risk for the first MI in a diabetic patient is similar to that of a recurrent MI in a non-diabetic patient who has had a previous event. This slide manifests that at the heart of the metabolic syndrome lies insulin resistance and all the comorbid conditions that it can lead to, namely hypertension, dyslipidemia, visceral obesity, type 2 diabetes, and ultimately atherosclerosis. Cardiometabolic risk refers to a high lifetime risk for a cardiovascular disease. It is a condition in which the possibilities of developing atherosclerotic cardiovascular disease and diabetes are significantly enhanced as a consequence of the presence of the metabolic syndrome. Cardiometabolic risk is similar to the metabolic syndrome, but it is more inclusive as it also includes smoking and glucose in the diabetic range, not just the pre-diabetic range. The cardiovascular disease continuum is a sequence of cardiovascular events which begins from a cluster of cardiovascular risk factors consisting of diabetes, dyslipidemia, hypertension, smoking, and visceral obesity. If these factors are not intervened with early, they will progress to atherosclerosis, coronary artery disease, myocardial infarction, left ventricular hypertrophy, left ventricular dilatation leading to LV systolic or diastolic dysfunction, and eventually end in end-stage heart failure and death. So this slide shows the statistical significance of diabetes as a cardiovascular risk equivalent and exemplifies the increase in MACE for diabetic patients who have had a prior MI versus a non-diabetic patient. So what's the game plan? Screen for diabetes and its comorbidities, manage the tobacco, the lipids, blood pressure, and glucose in everyone, and aspirin therapy for selected patients. So expanding upon that, statin therapy should be added to lifestyle therapy, regardless of a baseline lipid level for diabetic patients. Blood pressure goals should be aimed at a systolic of less than 130 and a diastolic of less than 80. Aspirin therapy anywhere from 81 to 162 as a primary prevention strategy in those with increased risk for both men and women less than 50 years of age. Previously, the age for women was 60. They've lowered that down to 50. The 4S study was one of the landmark studies that confirmed the efficacy of statins in the role of primary and secondary prevention of CAD. Published in 1994, the Scandinavian Simvastatin Survival Study, or 4S, randomized 4,444 patients with CAD and hyperlipidemia to either simvastatin or placebo. The trial was stopped early due to a 3.3% absolute reduction in all-cause mortality with simvastatin and a 55% and a 32% risk reduction in MACE in the diabetic and non-diabetic patients, respectively. The UK Prospective Diabetes Study, or the UK PDS, was a landmark study that showed conclusively that the complications of type 2 diabetes could be reduced in improving blood glucose and or blood glucose control. The study, which ran for about 20 years and had a 10-year follow-up, recruited over 5,000 subjects from 23 sites in the UK. Results were presented in 2008. The trial showed that ACE inhibitors, namely captopril, and beta blockers, namely atenolol, reduced the risk of developing clinical complications. The 2016 executive summary to the type 2 diabetes management algorithm represents the official position of the American Association of Clinical Endocrinologists and the American College of Endocrinology. It's used to serve as a practical guide that considers the patient as a whole, their spectrum of risks and complications, and evidence-based approaches to treatment. It was originally drafted in 2013. The update to the algorithm basically covers new treatments, management strategies for type 2 diabetes, and key clinical data, including a new section on lifestyle therapy optimization. So here I have listed 12 principles of the AACE and the ACE recommendations. Some of the more important ones I highlighted in pink. Like lifestyle therapy, including medically supervised weight loss, is key to management of type 2 diabetes. The A1C target must be individualized. So it's hard to put that blanket number, but even though they have one out there, we still have to individualize the A1C target. Glycemic control targets, including fasting and postprandial glucoses. Minimizing risk of both hypoglycemia and weight gain is a priority. The algorithm stratifies choice of therapies based on initial A1C, and the algorithm includes every FDA-approved class of medication for diabetes. Here I've listed some of the major points in the comparison between 2013 and 2016 recommendations. Basically, the mandate incorporates an integrated consideration of micro and macrovascular risk, including cardiovascular risk, factors such as lipids, hypertension, and coagulation, rather than an isolated approach focusing merely on glycemic control. In addition, discussions of hypertension management, nephropathy management, hyperlipidemia, hypoglycemia, and anti-hyperglycemic therapy have been substantially revised and updated, focusing on safety beyond efficacy. So there have been 3 landmark diabetic pharmacology trials to date that have shown cardiovascular benefit. The PROACTIVE trial, which demonstrated over about a decade ago cardiovascular benefit from Actos. The EMPA-REG trial, which in 2015 showed cardiovascular benefit with Jardiance, and more recently the LEADER trial in March 2016, which gained a lot of excitement, exhibited a major cardiovascular benefit from Victoza. So in March 4th, 2016, the LEADER trial revealed that Victoza reduced the risk of major adverse cardiovascular events. The study, which began in 2010, followed over 9,000 patients with type 2 diabetes for about 5 years, compared them randomly assigned to Victoza or placebo, and along with standard treatment. The primary endpoint was defined as the composite outcome of the first occurrence of cardiovascular death, non-fatal MI, or non-fatal stroke. Trial met criteria for both non-inferiority and superiority for all 3 of the component endpoints. So now, Victoza is the 3rd glucose-lowering agent to show cardiovascular benefit and the first of the GLP-1 class. In 2010, Mount Sinai Heart launched the Diabetes Alliance. It was a program that offered diabetics an access to Mount Sinai registered dietitian or a certified diabetes educator in their primary care practice or setting. The mission of this program was to establish cohesive relationships throughout the New York metropolitan area by integrating Mount Sinai's preventive and population health medicine programs into practice. And their goals were basically to introduce the critical role that evidence-based diabetes management and clinical operational protocols and standards play in the delivery of quality-focused care, to embed a registered dietitian or a diabetes specialist to disseminate best practices and reduce diabetes-related complications, as well as to implement an infrastructure that supports optimal clinical processes and outcomes. So basically, the management of the diabetes educator was to identify the high-risk patient. And the high-risk patient was defined as a patient that had an A1C of 8% or higher. To perform an assessment, collaborate with the patient's PCP and customize a plan of care, and to review the treatment plan changes with the patient, and assist with scheduling follow-up of patients. It was very successful, actually, here at Mount Sinai. So in summary, told you I'd be quick. A multi-specialty collaboration must be used for the diabetic management of the patient with concomitant diabetes and cardiovascular disease to decrease cardiovascular risk, hyperglycemia, and ultimately improve outcomes. We must remember patient-centeredness approach is key. And we also have to remember that diabetes should be treated across the lifespan to help patients living with diabetes transition through different stages of life. With cardiovascular disease as the #1 cause of death and a major worldwide public health problem, and diabetes fast becoming a world pandemic, preventive measures must be taken as a matter of urgency. Thank you.